Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 325 of our pharmacotherapy series, which majors in diabetes mellitus. The first question refers to patient PAH from parts 323 and 324 of this pharmacotherapy series. PAH was instructed to inject herself with 12 units of insulin glargine each evening and to give 4 units of insulin aspart just before each meal. She was asked to test her blood glucose 4 times daily, that is before meals and at bedtime, to record her results and other unusual events or symptoms during the day, and to bring her blood glucose logbook to the clinic. PAH was also instructed to track her food and record the number of carbohydrates she ingested at each meal. The initial goal of therapy is to lower her to eliminate symptoms of hyperglycemia. The ultimate goal is to achieve fasting glucoses of 80 to 130 mg per deciliter and postprandial values of less than 180 mg per deciliter. 1 week later, trends in her blood glucose concentrations were as follows. At 7 a.m., the glucose concentration is 160 to 200 mg per deciliter. At noon, the glucose concentration is 220 to 260 mg per deciliter. At 5 p.m., the glucose concentration is 130 to 180 mg per deciliter. At 11 p.m., the glucose concentration is 140 to 180 mg per deciliter. Occasional 3 a.m. tests averaged 160 mg per deciliter, and PAH's urine is negative for ketones. She eats approximately 4 carbohydrate servings for breakfast, that is 60 grams, and 2 to 4 carbohydrate servings for lunch and dinner, that is 30 to 60 grams. Subjectively, PAH feels a bit better, and her weight has stabilized, but she still urinates 2 to 3 times nightly. How would you interpret these results, and how should PAH's insulin doses be altered? Values from self-monitoring of blood glucose appropriately form the basis for insulin adjustments. Ultimately, the goal is to move motivated patients toward being able to recognize their own glucose trends and make insulin adjustments accordingly based on recommendations between the patient and provider. Before using PAH's blood glucose results to adjust her insulin dose, it is important to observe and reassess her testing technique. One also should determine whether there were any unusual circumstances in her life, such as acute illness, diet changes, drug therapy changes, or exercise patterns during the past week that may have affected her response to insulin. Once these have been ruled out as confounding factors, one can begin making adjustments in PAH's insulin dose, realizing that fine-tuning will be impossible until a consistent diet and exercise pattern have been instituted. Several principles must be kept in mind whenever blood glucose tests are used to adjust a patient's basic insulin dose. Because many factors can alter a patient's response to insulin, it is important to review blood glucose concentration trends measured for a minimum of 3 days to adjust the basic insulin dose, i.e., the dose the patient will use every day. The only exception to this rule is the use of supplemental insulin doses to correct exceptionally high glucose concentrations after PAH has acquired sophisticated insulin adjustment skills. Self-monitoring of blood glucose results should always be evaluated in conjunction with A1C values. The daily dose of insulin glargine is inadequately controlling PAH's fasting plasma glucose and should be increased by 2 to 4 units. A more conservative approach would be to increase the dose to 14 units each evening, or a designated time of day that she will be able to do consistently, and further titrate as needed. She is achieving some response from her lunchtime dose of insulin aspart, but there is room for improvement in her meal insulin coverage overall. The blood glucose concentration of 160 mg per deciliter at 3 a.m. indicates that rebound hyperglycemia is an unlikely cause of her high fasting levels. As an initial step toward control, PAH's daily dose of insulin glargine should be increased in an attempt to control her fasting hyperglycemia. However, this approach does not address PAH's elevated pre-lunch values. Her intake of carbohydrates also varies from meal to meal. Thus, a more appropriate method would be to calculate the insulin-to-carbohydrate ratio for PAH and allow her to determine her pre-meal aspart dose based on the amounts of carbohydrates she will ingest at each meal. A typical starting point for the insulin-to-carbohydrate ratio is 1 unit to every 15 grams of carbohydrate ingested. To calculate her insulin-to-carbohydrate ratio, the 500 rule is used. Divide the number 500 by her total daily dose of insulin, that is 14 units of insulin glargine plus 12 units of insulin aspart for meal coverage, which totals to 26 units. 500 divided by 26 is equal to 19 grams carbohydrate covered by 1 unit of insulin. Because most single servings of carbohydrate contain 15 grams, PAH decides to start with a ratio of 1 unit for every 15 grams or single serving of carbohydrates she consumes at each meal. If PAH were using regular insulin for meal coverage, she could use the 450 rule. 450 divided by the total daily insulin dose yields grams of carbohydrate covered by 1 unit of insulin. To evaluate the accuracy of her insulin-to-carbohydrate ratio, PAH will need to check her blood glucose values 2 hours after each meal, that is postprandial, to assess the appropriateness of her ratio. She agrees to test her blood glucose level 8 times per day and return in 2 weeks. PAH is getting more comfortable with carbohydrate counting and adjusting her insulin doses accordingly. A review of her food diary reveals that for the most part, she is able to determine the appropriate serving sizes for 15 grams of carbohydrate. She admits to difficulty determining carbohydrate amounts when eating out. As a result, PAH notices that her preprandial blood glucose concentrations exceed her goal of 80 to 130 mg per deciliter on occasion. Sometimes they are as high as 200 mg per deciliter. Evaluate PAH's blood glucose trends. How should occasional preprandial glucose concentrations that exceed the desired goal of 80 to 130 mg per deciliter be managed? Once the basal insulin dose and insulin to carbohydrate insulin dose have been established, one can begin to teach PAH how to use a correction factor to adjust her dose of insulin when preprandial blood glucose concentrations fall above or below the range of blood glucose concentrations that have been established as her goal of therapy, that is 80 to 130 mg per deciliter per the ADA. A correction insulin dose is used to compensate for unusually high blood glucose concentrations, that is a high sugar correction. To re-emphasize, this assumes there are no unusual changes in the patient's overall diet or exercise patterns, explains the effects of exercise on blood glucose. Many clinicians favor rapid-acting insulin versus regular insulin because its action is brief and patients do not have to worry about residual effects 3 to 4 hours after its injection. This is particularly valuable when correctional doses of insulin are needed at bedtime. The patient's sensitivity to insulin, as reflected by his or her total daily dose on a unit per kilogram basis, is a major determinant of any algorithm developed. A general approach is to give an additional 1 to 2 units of supplemental rapid-acting insulin for each 30 to 50 mg per deciliter elevation above the target level. An alternative method of estimating the drop in a person's blood glucose per unit of regular insulin is the 1500 rule. The derived value is referred to as the sensitivity factor. The rule was modified to the 1800 rule, for use with rapid-acting insulin, insulin lispro, aspart, or glulazine. Because these insulins tend to drop the blood glucose level faster and farther, 1500 turns out to be too aggressive. Others have recommended other numerators such as 1600, 1700, 2000, and 2200. For this case, the 1700 rule will be used. The calculation for PAH would be as follows: 1700 divided by 24, which is equal to 70 mg per deciliter. Thus, 1 unit of insulin aspart for PAH will drop her blood glucose level by about 70 mg per deciliter. People with a lower sensitivity factor, that is a higher insulin requirements, typically achieve a smaller reduction in blood glucose per unit of insulin compared with those with a higher sensitivity factor, that is a lower insulin requirement. Thus, an algorithm of 1 unit of insulin aspart for every 70 mg per deciliter excursion above her goal of 120 mg per deciliter is a reasonable place to begin. If this dose of insulin is insufficient, one can decrease the blood glucose excursion required per unit of insulin dose, e.g., 50 mg per deciliter. Correctional insulin doses also are used for sick day management. The following is an example of a high sugar correction algorithm for PAH. For glucose concentrations of below 80 mg per deciliter, she requires 1 unit less insulin aspart. For glucose concentrations of 80 to 120 mg per deciliter, she requires the usual dose of insulin aspart. For glucose concentrations of 120 to 190 mg per deciliter, she requires 1 unit extra of insulin aspart. For glucose concentrations of 191 to 260 mg per deciliter, she requires 2 units extra of insulin aspart. For glucose concentrations of 261 to 330 mg per deciliter, she requires 3 units extra of insulin aspart. For glucose concentrations of 331 to 400 mg per deciliter, she requires 4 units extra of insulin aspart. PAH returns after 1 month. She is currently using 14 units of insulin glargine each evening, 1 unit of insulin aspart for each 15 grams of carbohydrate ingested at mealtime, and a high sugar correction factor of 1 unit of insulin aspart for every 70 mg per deciliter above 130 mg per deciliter. Presuming that her diet is consistent, her self-monitoring of blood glucose results are as follows. At 7 a.m. the blood glucose concentration is 140 to 180 mg per deciliter. At noon the blood glucose concentration is 120 to 150 mg per deciliter. At 5 p.m. the blood glucose concentration is 90 to 130 mg per deciliter. At 11 p.m. the blood glucose concentration is 90 to 120 mg per deciliter. At 3 a.m. the blood glucose concentration is 60 to 90 mg per deciliter. The next question reads, overall, PAH feels her diabetes is in good control. Her energy level has returned to normal, and her nocturia has diminished, but she occasionally gets up 1 or 2 times nightly to urinate. PAH has also noticed that nightmares or sweats sometimes awaken her. When this occurs, she generally has something to eat because she is famished. She is able to get back to sleep, but wakes up the next morning with a splitting headache and a hungover feeling. PAH's weight remains the same, and she has begun to develop some consistency in her dietary patterns with the help of a dietitian. She has been consistently correcting her pre-lunch and pre-dinner insulin doses by adding or subtracting 2 units from her pre-meal insulin doses based on her pre-meal blood glucose values. The A1C from her last visit is 7.3%. Evaluate PAH's blood glucose values. What are possible causes of PAH's fasting hyperglycemia? When evaluating morning hyperglycemia, several causes must be considered. 1. An insufficient basal dose of insulin. If the basal dose is insufficient, hepatic glucose output during the fasting state will be excessive, thereby producing hyperglycemia. 2. Insufficient dinner coverage with insulin aspart, resulting in hyperglycemia that persists into the morning. This can be distinguished from an insufficient basal insulin by assessing glucose control at bedtime. 3. Reactive hyperglycemia in response to a nocturnal hypoglycemic episode, also called Somogyi effect or rebound hyperglycemia. 4. An excessive bedtime snack. And 5. The dawn phenomenon. The presence of normoglycemia at bedtime, low blood glucose concentrations at 3 a.m., and symptoms of nocturnal hypoglycemia, e.g. nightmares, sweating, hunger, and morning headache, in PAH are consistent with a rebound hyperglycemic reaction in the morning, i.e., post-hypoglycemic hyperglycemia, also referred to as the Somogyi effect. Theoretically, this effect occurs after any episode of severe hypoglycemia and is secondary to an excessive increase in glucose production by the liver that is activated by insulin counter-regulatory hormones such as cortisol, glucagon, epinephrine, and growth hormone. The waning effects of the basal insulin dose can also be a cause of fasting hyperglycemia because insulin is needed to suppress hepatic glucose output during the fasting state. However, this is not likely in PAH's case. Asymptomatic nocturnal hypoglycemia can occur in patients taking more than necessary doses of insulin in the evening and may potentially cause rebound hyperglycemia in the morning. By correcting the nocturnal hypoglycemia, normalization of PAH's fasting hyperglycemia also may be achieved. Thus, a decrease in the daily dose of insulin glargine is warranted. PAH should continue to monitor her blood glucose concentrations at 3 a.m. to determine whether her blood glucose levels return to normal. As a caveat, if PAH were using neutral protamine hagedorn twice daily to supply her basal insulin, one option would be to shift the evening injection of neutral protamine hagedorn from before dinner to bedtime. This preferred method effectively shifts the peak action of neutral protamine Hagedorn to the early morning, when she is awake, and decreases the risk of nocturnal hypoglycemia. This peak action also corresponds to the dawn phenomenon and the breakfast meal. Another option if a patient is using neutral protamine Hagedorn and experiencing nocturnal hypoglycemia is to change from neutral protamine Hagedorn to either insulin glargine or insulin detamir, because these insulins are associated with less nocturnal hypoglycemia. When switching from neutral protamine Hagedorn insulin to insulin detamir, a 1-to-1 dose conversion may be used, although higher doses of detamir may be required. In one crossover study of type 1 diabetes patients, the average detamir basal dose was approximately double that of the neutral protamine Hagedorn basal dose. However, when switching from neutral protamine Hagedorn insulin to insulin glargine, a 1-to-1 dose conversion is utilized only when a patient is using neutral protamine Hagedorn insulin once daily. If a patient is taking neutral protamine Hagedorn insulin twice daily, then the total daily insulin dose should be decreased by 20% when switching to insulin glargine. In this case of PAH, the daily dose of neutral protamine Hagedorn should be decreased by 20% to determine the insulin glargine dose to err on the conservative side. Although PAH's pre-lunch blood glucose values are above her goal, this may be attributable to the fasting blood glucose being elevated and then continuing to be elevated mid-morning, like a domino effect. It is important to first correct fasting hypoglycemia and generally correct one blood glucose concentration at a time. The next question reads, if PAH were to use neutral protamine Hagedorn as basal insulin, how should she be instructed to measure and withdraw this insulin mixture? Although mixing two insulins in the same syringe has become less common with use of basal bolus therapy, because insulin glargine and detamir cannot be mixed, and the use of rapid-acting insulin pen devices, the procedure used to mix and withdraw neutral protamine Hagedorn and mealtime insulin, regular or rapid-acting insulin, is basically the same as that described in case above. The major difference is that an adequate volume of air must be injected into the neutral protamine Hagedorn vial before the regular or insulin aspart is measured and withdrawn. Also, the mealtime clear insulin is measured and withdrawn into the insulin syringe first to avoid contamination of the vial of regular, aspart, lispro, or glulisine insulin with neutral protamine Hagedorn. For example, contamination with neutral protamine Hagedorn ultimately alters the neutral protamine Hagedorn to regular insulin ratio that is administered. When patients withdraw neutral protamine Hagedorn insulin first, the vial of regular insulin eventually becomes cloudy. In contrast, contamination of the neutral protamine Hagedorn insulin with regular insulin is insignificant because the protamine contained in neutral protamine Hagedorn can bind the regular insulin. The procedure PAH should use to mix her insulins is described in the following section, using her morning dose as an example. 1. After dispersing the neutral protamine Hagedorn insulin suspension, inject 14 units of air into the neutral protamine Hagedorn vial and withdraw the needle. 2. Inject 7 units of air into the insulin aspart vial, and withdraw the 7 units of insulin as described in case above. 3. Insert the needle into the neutral protamine Hagedorn vial, and pull the plunger down to the 21-unit mark, that is 14 units of neutral protamine Hagedorn plus 7 units of insulin aspart. The next question reads, will mixing neutral protamine Hagedorn with a rapid-acting or regular insulin blunt the rapid action of the mealtime insulins? How stable are other insulin mixtures? Regular insulin and all of the rapid-acting insulin analogues, aspart, lispro, and glulisine, may be mixed with neutral protamine Hagedorn. In general, it is recommended to mix the insulins just before administration. However, with the increased use of insulin pen devices, mixing of insulins in the same syringe has become a less common practice. The next question reads, after reducing the dose of insulin glargine to 14 units each evening, PAH's fasting plasma glucose is now 110 to 125 mg per deciliter. However, her noon blood glucose concentrations remain in the 120 to 150 mg per deciliter range. Are there any other changes that you would recommend to make at this time? When evaluating mid-morning hyperglycemia, it is important to remember that the fasting plasma glucose concentration can contribute up to 50% of this plasma glucose excursion. Therefore, a key to the control of mid-morning hyperglycemia may be to normalize the fasting glucose concentration. However, for PAH, the reduction in the insulin glargine has now corrected the reactive fasting hyperglycemia. Hyperglycemia before a meal can be a result of several factors. The following are possible explanations for PAH's mid-morning hyperglycemia. 1. An insufficient dose of insulin aspart before breakfast. For PAH, this means that her insulin-to-carbohydrate ratio needs to be adjusted. 2. Excessive carbohydrate ingestion at breakfast or inaccurate, that is, under-counting of the carbohydrates ingested. Patients having difficulty accurately counting their carbohydrates should meet with a dietitian or diabetes educator for education. This is often necessary periodically throughout their lives as a refresher, just like many other skills require. 3. Poor synchrony between meal intake and insulin action. This could be caused by administration of rapid-acting insulin too long before or after the meal, e.g., equal to or longer than 30 minutes. If regular insulin is used, this could be caused by administering regular insulin just before or after meals. 4. An insufficient dose of evening insulin glargine to suppress hepatic glucose production, that is glycogenolysis and gluconeogenesis, during the fasting state or the dawn phenomenon. However, in PAH's case, her fasting plasma glucose values are in target, so this is not likely. The following interventions may be considered. 1. Adjust her insulin-to-carbohydrate ratio to increase her insulin aspart dose at breakfast. The ratio should be changed to 1 unit of aspart for every 10 or 12 grams, which are typical ratios used, of carbohydrate for the breakfast meal. This assumes a patient is technically able to use a different ratio at different mealtimes. 2. Alter the carbohydrate content of the meals. This may include decreasing the amount of carbohydrate in the breakfast meal, changing the type of carbohydrate ingested, or adding fiber to that meal to minimize glucose excursions. 3. Adjust the high sugar correction factor if the glucose excursions appear to be caused by reduced insulin sensitivity in the morning. For example, the high sugar correction can be adjusted to give 1 unit of aspart for every 50 mg per deciliter above 130 mg per deciliter. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 326.